Thank you, Lynn. Before I start, I just want to acknowledge Lynn doesn't do service to what she and her husband Mike have done. From their tragedy, they have turned it into helping so many families. They actually are leaders of our 12-week Family Connections program. They run 3 groups a week. And Alan Frazzetti and I had dinner last night with Lynn and Mike, and we were amazed. Running 3 groups a week for a very intense program is incredible. So I ask you to join me in a round of applause for Lynn and Mike for all that they are doing for other people. This shows that I have no conflicts of interest, which is a good thing. So let's start out with my, as Lynn calls it, my bonhomme, my little man here, or my little woman. And the reason that I have put together this slide, because I think it well depicts what it's like to live the borderline experience. In the center is what we have, which is just dysregulation. And what branches out, first of all, is emotion dysregulation. People with the disorder, and I'll give you a definition that's very concise, but if you walk around this image here, I think it well depicts what it's like to live with the disorder. It's emotion dysregulation, it's cognitive or thinking dysregulation, it's self-dysregulation, interpersonal dysregulation, and behavioral dysregulation. All of these are intertwined, and there could be arrows going from each bubble to the next and going back from the other bubble. So this represents an image of what it's like to have the disorder. And a definition is borderline personality disorder is a disorder of the emotion regulation system that occurs in the context of another person and is identified by intense and unstable moods, erratic and impulsive behaviors, and chaotic relationships. So a way to think about this is an individual who has problems managing their emotions, and what happens is in the interface and in the context of relationships, these symptoms get displayed and played out. We often think that if somebody lived on an island, they probably would not look borderline because there's not another person to interface with. And what I'll show you in a few minutes when we go through the symptoms, I'll ask you to identify what you've experienced, but 7 out of the 9 symptoms impact relationships, and that's quite different from other psychiatric disorders. I mean, certainly having a loved one with depression impacts those in their environment and those who care about them, but the symptoms per se don't impact the relationship. And so I think it's very important when we think about BPD, we think about it in the context of relationships. I'd just like to go through, before we go through the symptoms, of what are the hallmarks of this disorder. There are actually 3 categories that we can think of that really highlight what this disorder is about. And the first is mood instability. They're mood extremes with quick mood changes, often brought on by interpersonal interactions, issues, and conflicts. There are fluctuations between sadness, anger, irritability, anxiety, shame, exhilaration, and many other emotional states that people can think of. And these changes occur in a matter of minutes. Oftentimes I'm asked, well, what's the difference between bipolar disorder and borderline personality disorder? And the first statement that I make is that they both have mood changes, but the length of the mood changes vary in time. So someone with BPD can have mood changes over dinner, where someone with bipolar disorder, the mood changes last for several weeks or months. So although there's a lot of confusion between these 2 disorders, it's one of the things to think about is the rapid change in the mood that really highlights BPD. There are other things as well, but this is the hallmark of BPD is this rapidity of mood change. The second category is suicide and self-harm. Self-injury is seen in 75% of patients with BPD, and most prevalent are cutting, burning, bruising, head banging, biting, and there are many others. I have a client who picks her skin, picks her scalp. So there are a lot of different ways that people can self-harm, but it's a hallmark of the disorder. 65 to 70% of people make at least one suicide attempt in their lifetime, and usually if they've made one, it's more on an average of 3 suicide attempts. 8 to 10% of patients with BPD complete suicide. This statistic actually has gone down. Up until about 5 years ago, it was 10%, but I think we're fortunately seeing a bit of a reduction in the suicides, and which hence the percent is going down. But it's 50 times higher than the general population, which is really incredible when you think about that 50 times more people in the BPD community are committing suicide. And BPD accounts for 18% of all suicides in the United States and 33% of all adolescent suicides. It's a shocking statistic to think that 1/3 of our adolescents who are killing themselves have BPD, and I can bet that most of them haven't been diagnosed with borderline personality disorder. And unfortunately, it's too late for them. But unless we get in early and do early intervention and detection, this disorder is not going to turn around. We held a symposium last year at the American Psychiatric Association with 25 of the leading international experts, and we are in the final stages of presenting a white paper on the importance of diagnosing early. There was a statement that was said for over many years that said you can't diagnose after 18. And what I like to say is you must diagnose before 18 because that's where we're going to make the most difference. So our third category when we think about the disorder and a hallmark of it is chaotic relationships. Intense interpersonal conflicts, often with frequent arguments. Many relationships are short-lived and end abruptly. Others endure for long periods of time with a pattern of endings and resurrections. So those of you who have a loved one with BPD, we hope that you stay the course because that's, as you'll see later, what's crucial for people getting better. But the relationships are difficult and they're challenging. And part of what happens, unfortunately, for loved ones, and even the person with the diagnosis, is that they don't get the diagnosis. So people are not even sure what's happening, and they see the behaviors as being willful and as being manipulative and words that we don't use. But the reality is it's an illness. It's an illness that occurs in the context of relationships, and part of the symptomatology is chaotic relationships. So public awareness that people realize that this is a disorder and not somebody just being willful or mean-spirited is crucial. So now let's go through the list of symptoms. And I'm going to ask you, I'm presuming most of you are family members, and maybe some of you are have a friend with the disorder, or perhaps you have the disorder. But those of you who have a relative with the disorder, as I go through the symptoms, what I'd like you to do, I'm going to ask you to raise 2 hands. The first hand is if your relative, or if you believe your relative has that symptom. And the second hand I'm going to ask you is, does that symptom impact you? Because remember I said 7 out of the 9 symptoms impact relationships. So I'm trying to get us to show each other how serious these symptoms are on all of you, who are, to me, the heroes, along with your relative who has the disorder. So how many of you know that your relative has fears of abandonment? And how many of you would say that that impacts you, the fears of abandonment? Okay, thanks. I'll give you a quick story from my clinical experience. I worked with a mother and her daughter who was 25 at the time, and the daughter had this symptom. These symptoms actually are in order of prevalence. So the number 1 symptom for BPD is fears of abandonment. And the daughter would call the mother about 10 or 15 times a day at her job. And the mother would keep asking her not to call because she was afraid she'd get fired. And when the mother changed jobs, what do you think she did? What was she forced to do? Anybody have a guess? A guess here? That's exactly right. She didn't give the number. And so, of course, what happens, and it was understandable, she didn't want to lose her job, but the problem is that behavior also reinforced the fears of abandonment, which is why we so crucially need skills to help families understand that they're being asked to react to abnormal situations, and they need skills to be able to effectively manage those situations. So fears of abandonment is the number one symptom. How about problems of unstable or intense relationships? How many of your relatives? Oh, I'm seeing double hands going up. Okay, thanks. How about unstable self-image, struggles with identity or sense of self? Yeah. Let me just put a little understanding into this. Imagine that with all of these symptoms, you don't feel like you could depend on yourself, and your sense of who you are is not built on a solid foundation. I mean, all of us, when we go have different opportunities or areas of our lives, we act a little differently. That's just normal, right? The way you act at home is different than maybe you'll act at a party, or maybe that you'll act in a clinical setting. I mean, that's just appropriate. But for someone with a disorder, they don't have any sense of a stability of that self. So there's not an anchor point for them where they feel that they're comfortable, this is who they are, and they can count on themselves, and that they're predictable. The next is impulsive or self-damaging behaviors, for example, excess spending, unsafe sex, substance abuse, reckless driving. How many people's loved ones have that? And how does that affect you? Does it affect you? Yeah, okay. The next is suicidal behavior or self-injury. How many people's loved ones have experienced that, and how does that affect you? Yeah. This one I often wonder, I'm not a family member, I'm a clinician, but I know as a clinician it's often hard to be at the other end of a phone call knowing that that client or patient has a bottle of pills or a knife and is about to do something. I can't imagine what it's like to be a family member and get that call in the middle of the night. Families truly are on the front line here, and as much as we'd like to think the therapists are, it's really the families who are interfacing all the time and managing these crises immediately. How about varied or random mood swings? Does your relative or loved one experience that? Does that impact you? Yeah, you bet. Chronic feelings of emptiness. This is a harder one to know if your relative feels this. When I do an evaluation with a client, I'll ask them about that sense of emptiness. I'll sometimes get a blank stare because they have no idea what I'm talking about. And that's a hallmark for me to sort of steer away a little bit, maybe from BPD. Or I'll get yes, and then not that confirms that they have the disorder, but they know what that word means. They live it. It's what they live and breathe every day. And it's a very powerful symptom for them, that feeling of emptiness. And when you ask them to describe it, it's very hard to put words to what that feels like. Intense anger or difficulty controlling anger? Yeah, okay, yeah. And how does that impact you? Double hands. And the last is stress-related paranoia or loss of contact with reality. When you think about all of these other symptoms, that you get emotionally dysregulated, that your mood swings are up and down, that you're fighting with people, that would make all of us sometimes dissociate or even get a little paranoid. So the combination of some of these symptoms create then, I think in part, this ninth symptom, and it also can stand on its own, that people with the disorder sometimes have a loss of reality for a few minutes, a few days, whatever. But so these are the 9 symptoms. You need 5 to get the bona fide disorder. But I would also venture to say that you don't need 5 that your life be held by borderline personality disorder. So I think it's important that we don't stick to that as the Bible, because these symptoms standing on their own are pretty hard to manage life with. So what are the many challenges about BPD? And there are many. There are doctors who are not interested in treating patients with this disorder. There's very little information, very little public awareness about the disorder. It's under-recognized, it's underdiagnosed, it's misunderstood, and it has a lot of surplus stigma. So when you ask most clinicians who are in the field and doing research, it often comes out that it takes up to 5 years for someone to get the diagnosis of borderline personality disorder. And as Lynn shared before, her daughter at 15 knew she had the disorder. She didn't get the diagnosis until she was 20. So it's incredible that people are living with something that they don't know what it's about. So not only is it underrecognized, it's also underdiagnosed. So just like we talked a few minutes ago about bipolar disorder and the mood instability, people often get diagnosed with bipolar disorder when they often have borderline personality disorder. Let me also make it clear that you can have both, so we're not saying that both don't exist, but the problem is that the bipolar disorder for clinicians often feels more comfortable. You can give a medication. There's no specific medication for BPD. It's usually the co-occurring disorders that get more of the medication. As my friend Ken Silk said, there's no medication for emptiness. So unfortunately, although our folks are on a lot of medications, they're not really addressing borderline personality disorder. And there's incredible surplus stigma. I did a research about 15 years ago where we compared family members who had a relative with borderline personality disorder and a relative with schizophrenia. Now, for me, and always before I became involved with BPD, I always thought of schizophrenia as the prototype mental illness. It's not what you want to get, it's a scary illness, it's a death sentence, etc. So you would think that the families who have a relative with schizophrenia would have rated higher on all of these scales. Well, in fact, they didn't. Grief and depression were the same. So families who have a relative with schizophrenia were the same as families who have a relative with borderline personality disorder. But what our families and in the BPD community rated higher was burden and stigma. So we have coined the term surplus stigma. This is a disorder with surplus stigma. NAMI, which is the National Alliance on Mental Illness, and the Voice of Mental Illness in the United States, has joined us in that idea that this is the most stigmatized of all mental illnesses. And the bottom line says 40% of borderline patients are previously misdiagnosed as bipolar disorder. I mean, that's incredible. I mean, think about a medical diagnosis and 40% misdiagnosed. I mean, I don't think that the physicians would tolerate that. Somehow in our community, this has been allowed to go on, although there's a sea change, and so we're getting to a better place. But it's quite remarkable that there's been such a high misdiagnosis. And BPD rarely stands alone. In my practice, and I've been working with borderline patients for I guess almost 30 years now, BPD rarely stands alone, and I've never seen a patient without another co-occurring disorder, which means that not only is there borderline personality disorder, but there are other disorders as well that circle around this. And you can see them. There's eating disorders, major depression, substance abuse, antisocial personality. Borderline personality disorder is the core here. Anxiety disorder, avoidant, histrionic, narcissistic, and believe me, there are many more. And what I've always found in my practice, which really trips up treatment most, is when there's an eating disorder and where there's substance abuse. For some reason, those two disorders make the treatment harder. There's also a statistic that shows that when somebody has major depression and they are not identified as also having borderline personality disorder, that it takes longer time for the major depression to remit. So unfortunately, people who are experts in these other fields are not looking for borderline personality disorder. We as BPD clinicians are always looking for the co-occurring disorders, but unfortunately, it's not true for the other disorders. One other thing that should be on this slide is attention deficit disorder, and this is what we often think now is in part a precursor. I attended a conference, I think 3 years ago in Florida, where there was an expert on ADD, and someone asked him about borderline personality disorder, and he sort of just shrugged and said, "Oh, no, we don't really think about that." He said, "But we do have an expert here on the disorder, so maybe she can talk about it." But it shows that how other disorders are not joining us in partnership for this comorbidity. So what's the outlook? BPD is a good prognosis diagnosis, whereas before it was thought as a death sentence. After 2 years, more than 50% of patients recover. After 10 years, more than 80% recover. And 88% in recovery stay in recovery. And this is the work of Dr. Mary Zanarini up at McLean Hospital, who has done an incredible longitudinal study. She's now, I think, either into her 18th or 20th year, where she's tracking about 400 patients over that time to see how they're doing. This is not a treatment study, so we can't say, well, it was this treatment that did it. It's really just a longitudinal study tracking these patients. So what does improve? And I think this is important. What improves first is impulsive behavior. And there's a saying that I heard many years ago is that if you can get a patient to survive till 40, they probably won't kill themselves. And it's the impulsive behavior that really is addressed, that really needs to be addressed, because that's where we're going to save lives. And fortunately, that's the thing that most improves. But I'm not so sure it's not just aging out too. I think as we get older, we just have less impulsivity and things. The next is cognitive and interpersonal changes. Those change next. And the last thing to change, and I think this is hard because this is what probably, along with the suicide attempts, impacts the relationships, are mood instability. That changes the least and the last. But it does change. But if you look at all all these symptoms decline, but not equally. So there are ongoing problems, however, and unfortunately, we talk about people being in recovery, but we don't talk about what's being missed. And what that is that disability and unemployment remains high. 39% of people with the disorder, and I'm not sure what state, because I know I've never in my work with people with the disorder have ever filled out a disability paper. I think work is crucial, but 53% of people with the disorder are unemployed. And I think what happens also is that people get off track. So how do you explain a resume that has a gap of 5 years? So it's a combination of things, but what we do need to do is work on getting people with the disorder either to work for the first time or back to work. And this was taken from a webinar that was last week, hosted by McLean Hospital and now NEABPD, where Lois Choi Kane talked about the disorder, and this was a statistic she identified. So what's the basic epidemiology? Well, the prevalence of the disorder, 20% of people who come for therapy outpatient have BPD, 1.2 to 5.9% of the general population have BPD, and 6% of people in a general medical practice, just seeing their regular doctor, have the disorder. In terms of gender, approximately 75% of females in clinical samples. That means people who present for treatment. But that's no surprise because women are more likely to go for treatment for anything. But it's really a more equal balanced thing in a community sample. Male versus female is about the same. What's also been identified is that unfortunately, probably some of the men with BPD end up in the penal system, so they're not part of the clinical samples that we see. So how does the disorder develop? Well, there's the biosocial theory, which says that there are inborn genetic factors, which we call emotional vulnerability, and there are environmental factors. And these factors interact with each other, which is why the arrows go up and down. Each alone does not necessarily mean the disorder will develop. It's the transaction between the two that create fertile soil for the disorder to develop. So there needs to be some sort of emotional vulnerability, and then something in the environment. Marshall Linehan calls it the invalidating environment, and I know that's become a popular term. I like to also think of it as an incompatible environment, and that there are just some times when a parent and a child are not in sync, and those of you who have more than one child, I'm sure know that you can read one child better than the other. So the biological characteristics are high emotional sensitivity. And the way I like to think about this is think about when you have a burn that's healing on your hand and you put it in the oven to pull something out. That wound feels the heat more quickly, so it's more sensitive. And so people with the disorder are more emotionally sensitive. that wound also is more reactive to the heat. People with the disorder are more reactive to what's coming at them. And what the last part is, which makes everything more complicated, is that people with the disorder are slower to return to baseline. They're slower to get back to an even keel. So if you're up here, you're more likely to be more vulnerable to the next emotional stimulation that comes your way. So you can see then how the combination of this high sensitivity, high reactivity, and slower return to baseline creates sort of a phenomenon that makes somebody more vulnerable to anything that comes their way. There's also the heritability factor, and just running down, you can see that BPD runs just about in the middle of being a heritable disorder. It doesn't mean that disorder per se is heritable. It means that some of the traits are. So someone might have a relative that gets angry, doesn't mean they have borderline personality disorder. So it's more the traits than that it's a guarantee that if there's a mother with BPD, the child will have BPD. The environmental factors, I put them in 3 categories. There's a poor fit between the child and his and her environment. And I want to say here that we have to look at all the environments the children grow up in. There's the family environment, we certainly know that. There's the church environment, the school environment, the social environment. There's so many different environments that children grow up in that we can't say it's the family environment that maybe lays that ground. The family environment can perhaps buffer it if the parents understand what's going on, but there are many environmental factors that go into helping the disorder develop. There's been reports about sexual abuse, 40 to 71%. When I started working in the field with this disorder, there was an insinuation that family members were the abusers. Well, 2 factors here. Family members are often not the abusers, and this statistic is way too high. Okay, in the non-BPD population, it's generally said that 25% of women are sexually abused before the age of 18. So we already start at a baseline. It doesn't mean that those women also develop BPD. So I think we need to continue to look at this sexual abuse thing specifically when it insinuates that family members are involved. And the last is the loss or abandonment as a child, and this can happen from so much that happens in life, a divorce, a death, relocation. Parents sometimes are neglectful. A parent might have a major illness, they're depressed themselves. So there are a lot of different factors, and again, it's the interaction. Remember those 2 arrows going up and down, it's the transaction that makes it. So the face of the disorder, there are 256 different combinations of the symptoms. So there's no one picture that accurately depicts BPD. So I now would like to invite Lynn Corey to come back up as a family member and share with you her thinking and what it's like to be at the end of being a family member. Lynn.
With the next few slides, I would like to share with you information on how BPD affects the family experience, what are some of the factors that make it difficult for us, for family, and what are some of the strategies we can use to improve our family experience, such as the family connection. The impact of mental illness on family. Research shows that the impact of mental illness on family is very severe. Families with loved ones with a mental illness often carries additional burden, grief, depression, anger, anxiety, shame, and sadness. Often it feels like a family failure, a personal failure. And for example, for us, with our daughter, we weren't inviting people over at home, or we weren't going places where our daughter didn't want to go because we wanted to avoid unpleasant outcomes. We were constantly walking on eggshells, and living like this was very exhausting. It felt that we were carrying an extra baggage on our shoulder that we could not share with anyone. Over the years, we were progressively isolating ourselves from the world. In fact, the impact of mental illness on families is so extensive that many families living with a loved one with BPD report symptoms of PTSD. The stress that families experience is ongoing, affecting everyone functioning, where everyone's energy is often depleted, making it more difficult to face the next crisis. This is how we develop the PTSD symptoms. And yet, study shows that family that can make a positive impact. In interviews with families, members of loved one with BPD inpatient, one element stood out in terms of how patient did over a 1-year period. The more emotionally involved the key relative were, the better the client fared. It predicted better clinical outcomes. For example, their studies showed the loved one with BPD had fewer rehospitalization. The well-being of the family members. We really need to acknowledge that there is considerable family burdens when with a relative has BPD. This often so hard for a family member to acknowledge, even harder to express it. But without recognizing the stress and the burden, we cannot deal with that appropriately and still have something left to give to our loved one. Just as we're told when we take a plane by the airlines company to put our own oxygen mask before helping others surrounding us, we need to follow the same patterns in our life when trying to help our loved one. The goal is really to find a balance in our own well-being and a balance for the well-being of our loved one, to be able to be effective in our relationship with them. It certainly took me a while to understand a concept called healthy selfishness. I said, oh my goodness, I cannot think about myself. I have to give my 200% to my loved one. She really needs me. I have to be there. Forget about me. And I realized I was so exhausted that I was making things worse. So today, I finally understand that in order to be effective in a relationship with my loved one, I cannot sustain doing that 200%. I have to practice healthy selfishness. It is essential for me to obtain my balance in my life in order to be able to be effective with my loved one. And this is why we say working together. As we heard from Perry about the biosocial theory, BPD is a relationship disorder that has both the genetic and the environmental component. There is relationship between the individual functioning and the family functioning. We know that relationship can make us feel either very good or bad about ourselves or others. So individual and family well-being are intertwined, and therefore it really makes sense to involve families in the treatment of our loved one. Involving everyone for a common goal, remove the stigma, remove the burden of responsibility or blame on one single person, and makes mental health a team effort. I would always say a community effort. In 2005, Perry Hoffman and her team developed a program designed specifically for relatives of people with severe difficulty managing their emotion. No one would disagree that the behavior that go along with the symptom can be help for the sufferer and as equal help for those who love them. So this is why Perry created a program called Family Connection. Before going into the details of the family connection, I just wanted to show you that diagram about the family dilemma, how it is important to be finding the dialectic of things. Tension in families often arise because we think in terms of opposites. When we think of opposite with our loved one, we may recognize some of the pattern on that chart. Life is full of seemingly polarized perspective. Here's a quick example. Sometime, I remember, we felt that we were prisoner in our own home, while like Sasha we felt that she was taking over the house. And then she felt that we weren't giving her enough space. At a quick glance, it doesn't look that we could find balance in those such opposing forces. And dialectics assume that there is no one absolute truth. Here's another example. I remember once my other daughter told me that she was ditched at the party. That for us, it felt very unfortunate, but it was manageable for us as a parent. And yet, for my other daughter, that was the end of the world for her. It was catastrophic for her. This is why it's important to try to find a way to learn skills that allow us to depolarize the situation and think more as a dialectics, that both situations may be true, and there's a way to find a common ground to coexist. We need, and this is what Family Connection does, find ways to better understand the other person's perspective, even when it's drastically different from our own. In a sense, if we depolarize our thinking, we don't argue about things we have in common. Few relationships are in conflict at all the times, and perhaps if we accept more from someone else, it's easier from the other person to make change. Here's one of the formats that we do with Family Connection. We send flowers in different communities, and then we offer a program that is a 12-week program of skills and support for family members. Family members who are attending the group can be either parents, partners, spouse, or sibling. And in this group, during those 12-week group, we offer to teach and to share our knowledge about some of the DBT skills and strategy that can help our family members to accept the situation, to be grounded, to find balance, to learn how to validate their loved one, to have a better perspective of what they're going through, to finally open the door to be able to do some problem management and problem solving. And this is run by family members. And I'm so excited to say that this coming weekend, we're doing a training with Dr. Alan Frizzetti for over 70 family members and mental health service provider to create more of those family connections in Toronto. So we're really pleased of doing this. And all those courses, those programs that we provide in the community, no charge. We're charging nothing for our family members to attend this program of 12 weeks. And then at the end of the day, they feel so much empowered. I still remember, I think the last course we did with my co-facilitator, we were giving the first class, and we've been doing those for the last 3 years. And at the end of the day, the parents applaud. And we looked at each other with my co-facilitator, what did we do different? And then when we thought about it, is they were so happy to feel that they weren't alone, that there was someone understanding what they were going through, and it was possible to find ways for them to find a balance and to be able, but that transactional model, the way they act and react, may influence the way that their kids or their loved one act and react, and to find a way to have a life worth living. So quickly, I'm going to just say what FC can do for you is by learning all those skills about the acceptance of the understanding your loved one, building trust, building connection, improving your own well-being, improving your relationship, problem management, asking for things. This is what the Family Connection program does for you. So if you want to have more information, at the booth at the back, we can give you more, because I know today time is restricted to explain to you what Family Connection during those 12 weeks are, but it is making a difference. and see us, and we can tell you more about it. And I would like to ask Perry just to come quickly and to talk about the National Institute of Mental Health brochure of what they say about the family connection.
Thank you, Lynn. So the National Institute of Mental Health is the United States government's way of doing research, and it's funding that comes through to grantees who want to research. And we've been very fortunate that what they said was they identified actually 2 programs. Some therapies, such as DBT Family Skills Training, DBT FST, include family members in treatment sessions. These types of programs help family develop skills to better understand and to support a relative with borderline personality disorder. This is a program where family members and the relatives are together, and it's a very powerful program, and we're at the point now of launching that to another level. And then other therapies, such as Family Connections, focus on the needs of family members. Oh, yeah. Thanks. So just quickly, what Family Skills Training is, it's the first program to ever use DBT with families, and that's Marsha Linehan's work. It's a 6-month weekly program in agency and practice settings. We've now reduced it down to a 12-week program. This program is led by professionals. It includes patients and families in a multiple family format. Its framework is DBT skills and strategies, and there's a consultation hour for skill application and problem solving. And that 1 hour is priceless, where a problem is put up by a family, other families help consult together with the person with the disorder, and it's an incredible experience. So as I said, we hope to get that to a wider audience. And this, I think we're out of time, but Lynn did a nice job of talking about the work that the National Education Alliance has done for borderline personality disorder. We invite you to go to our website, easy to remember, borderlinepersonalitydisorder.com. And I just want to close in reading something that a graduate of Mike and Lynn's Family Connections program wrote to them. I want to thank you from the bottom of my heart for all you've done for us, as well as for the time you gave us every Tuesday evening for 12 weeks. You give hope. Your courage in the face of so much pain has just blown me away. I don't think I would have made it through the last little while without the group. Knowing that I'm not alone in this, that other parents are going through the same hardships, has been very helpful. Family Connections is an amazing tool, and although it's not always easy to implement the strategies learned, they do work, and they have made a difference in my relationship with my daughter. The program is better than anything we have encountered in our almost 10 years of counseling and advice for mental health professionals. And so thanks to Lynn and Mike, and we have Winston and Vivienne here, and we have other Family Connections leaders. We have our leader from Italy who's brought Family Connections to Italy. We thank all of you for taking this program and making it bigger than we ever thought it would be, and we appreciate your acknowledgement that it's helped you so much. Thank you.
Thank you very much for 2 very nice talks. We'll take a few comments or questions right now, if you have some for Dr. Perry or Lynn Curry. Yes?
Thank you, Dr. I'm very encouraged that it says that you have a lot of chance of recovery. And we're in a place with our family where my family member has been through DBT. We've done a lot of the support. We've done the Family Connections. Everything is looking great. We're about the 2-year mark. But that sense of self and emptiness. I mean, this is a young woman who needs to be setting some goals for herself and for her relationships. And I feel like I still have to keep pushing for that. That when or how do we get that sort of sense of build your own life, for this young woman? Because she's come so far. She's in university, she's got a job, things are really improved, but there's still this sense of kind of drifting.
Well, I think that, I don't know if this is on. Can you hear me? I can't hear myself, so. Oh, it's on now. This does take time, and I think just like I said that there's some things that are last to remit. I mean, I think it's wonderful that she's in school. I mean, how do we all build a sense of ourselves? It's about our accomplishments and about our relationships, and that takes time. That's not going to happen so quickly. I mean, if the symptoms have been reduced and that she's able to function, in a school setting, it's the beginning. And I think it's a lot of encouragement that she continue to do what she's doing, but it does take time because the sense of self is not something that comes so quickly.
I do agree. It's not the direct focus of therapy, but it comes along when people make a life for themselves. So it may take a few years, but usually it comes after a few years. Other questions or comments? Yeah.
Bonjour. Moi, je me demande si j'ai bien compris. Je vais m'exprimer en français, ça va?
Oui, oui.
Je me demande si j'ai bien compris tout à l'heure quand on a parlé des problèmes de borderline. Est-ce que le trouble de... non. Est-ce que le déficit d'attention avec ou sans hyperactivité fait partie de ce groupe de problématiques? Est-ce que j'ai bien compris ça?
I'll try to answer. Dans la diapo qui est démontrée, où il y a beaucoup de comorbidité qui est évidemment qui doit être pris en compte en lien avec le trouble de personnalité limite ou borderline, il y a entre autres le trouble déficitaire d'attention avec ou sans hyperactivité. Maintenant, la psychiatrie moderne est un peu dans une phase de recherche par rapport à comment positionner le trouble déficitaire de l'attention, dans le sens où il n'y a pas un consensus encore à savoir jusqu'à quel point c'est vu comme étant une problématique qui doit être toujours traitée, puis dans quel point elle doit être adressée concomitamment. Dans notre expérience clinique que l'on a, mais là je dévie un peu, c'est que souvent les études ne sont pas faites en considérant la comorbidité avec le trouble limite, et on va se retrouver avec des adolescents, des jeunes adultes qui ont des troubles d'organisation, qui sont impatients, qui n'arrivent pas à accomplir des tâches, mais ça peut être autant une composante du trouble déficitaire de l'attention que quand même des éléments en lien avec le trouble limite. Alors, de bien différencier les deux, c'est très difficile, mais de bien différencier l'ensemble des problématiques, le trouble dépressif, le bipolaire type 2 avec le trouble limite, ça ne se fait pas habituellement en une entrevue de quelques minutes, ça prend beaucoup de temps. Mais oui, il y a de la comorbidité.
Thank you very much for the presentations. I have a quick question with regards to learning disabilities and BPD, in particular a nonverbal learning disability. But do we know, or is there a body of research that's looking at learning disabilities in general and nonverbal in specific and BPD?
I don't know of a study, but maybe Alan, do you know of a study? No. All right. But when you think about it, we don't even need a study, because when you have a disability, the environment does not know how to manage it well enough, with all good intentions. But I'm even thinking of kids with learning disabilities. They get pulled out to go to resource room. I mean, even that experience is enough where environment doesn't feel safe. They don't feel as though they're an integrated part of the school community. So there's so many different variations that happen with different life events. But learning disabilities has to be one where the environment just doesn't know how to adequately respond.
Okay. We'll take a last question, and you'll have time to interact with Dr. Hoffman and Lynn Curry at the break and in the dinner time. Oui?
Je vais parler en français. Okay. Je vais d'abord me situer comme personne. Ça va vous donner une idée pour laquelle je fais une intervention. Je suis directrice de l'Hôpital Québec, parent d'enfants présentant des troubles de l'attachement. Et lorsque vous décrivez les troubles de personnalité limite, j'aurais pu mettre le titre « trouble de l'attachement ». Alors, je voudrais savoir quel lien on peut faire avec le trouble réactionnel de l'attachement, les profils d'attachement désorganisés, désorientés. Plusieurs de nos enfants, à l'adolescence, on met dans les diagnostics symptômes TPL, mais on ne donne le diagnostic que très tardivement lorsqu'ils ont près de 18 ans. Et j'aimerais aussi faire un petit volet par rapport à l'adoption et aux enfants adoptés, tant ici qu'à l'international, actuellement, avec le contexte des réalités adoptives. j'ai une grande question, mais
Oui.
je termine ici. Merci.
Est-ce que, Lynn, tu abordes ces questions-là plus généralement,
Pas
pas
vraiment.
spécifiquement? OK, je ne suis pas un expert par rapport du tout aux éléments de pédo ou de troubles d'attachement. The question is more about attachment disorder in children and as a precursor of BPD, and also about international adoption. What is your understanding of these impact on the development of BPD in adults?
Well, I don't think we can ignore, I mean, we say this is a relationship disorder, so if there's problems in an attachment, how can that not impact something? And also, I think it's such a good question to ask about international adoptions, that children coming here, I mean, even if they are newborns, there has to be something that they feel different in the environment, and then some come at an older age and just ripped out of their country and a foreign language. I mean, again, we believe that there's probably a genetic piece as well, so we don't want to just say, well, if these events happen in one's life, they're going to develop borderline personality disorder. So we need the transaction of both, but I think those questions are excellent ones.
C'est clair que c'est des questions qui reviennent, qui sont dans un domaine où on a besoin de davantage de recherche, mais clairement, il y a des liens, des éléments à prendre en compte.